I'm Dr. Jennifer Hibberd, a co-author of the newly released scientific paper, Sharp Reductions in COVID-19 Case Fatalities and Excess Deaths in Peru, in close time conjunction, state by state, with ivermectin treatments. Here with me are my co-authors, Juan Chamie and Dr. David Scheim, and our colleague, the distinguished Dr. Pierre Kory. Let's begin with an overview of the results. I would like to introduce Dr. Scheim, who has a doctorate in math from MIT and did postdoctoral work in mathematical biology. He developed medical databases for the US National Institute of Health and now does independent medical research. David, please give a summary of the paper's findings.
Okay, pleasure to be with you. The mass distribution of ivermectin for COVID-19 treatment was authorized by government decree in Peru on May 8, 2020. Following that, the 25 states of Peru independently conducted mass distributions of ivermectin for inpatient and outpatient treatments of COVID, each autonomously, each in different timeframes. Now, 24 of these states conducted these mass ivermectin treatments early in the first waves of the pandemic, beginning in April, while Lima delayed treatments by 4 months until August. So in the early period, Lima serves as a control group. These 25 states span terrain from jungle to desert to mountain, and Peru is equivalent to an area from Florida to Minnesota to New York in the United States, or in Europe, from Denmark to Italy and Greece, with a combined total population of 33 million. We have, in effect, 25 different studies of ivermectin treatments in different large populations. This study was conducted using official health data from the government of Peru. Specifically, we used independently tracked data for COVID-19 case fatalities and also for excess deaths. We did not analyze COVID-19 case incidence because that is highly unreliable across a national population, as detailed in this paper. Now, I want to just show the graph here to the upper left shows the sharp drop in mortality after peak deaths in 8 of the 24 states of Peru with early ivermectin treatment. The red shows Lima, which delayed treatment by 4 months until finally the treatment happened and it dropped off to the right. The upper right shows independent but parallel data for COVID-19 case fatalities. We then extended our analysis to all 25 states of Peru. For 24 of the states with early ivermectin treatment, excess deaths dropped 59% at 30 days after peak deaths and 75% at 45 days after the day of peak deaths. But for Lima, these drops up at 30 and 45 days were each just 25%. Case fatalities likewise dropped sharply in all states but Lima, yet 6 indices of Google tracked community mobility data rose over the same period. Now let's look at figure 1D. This is the most striking feature of the analysis. For 9 states having mass distributions of ivermectin in a short time frame through a national program, Operation MOT, excess deaths at plus 30 days dropped by a population-weighted mean of 74%, each drop beginning within 11 days after MOT start. And again, look at the figure 1D on the lower right. Extraneous results and ruled them out, as will be covered in a few minutes.
Thank you, David, for your overview. Let me now introduce Dr. Pierre Kory to relate the significance of these findings and put them in context of current developments in COVID-19 treatments. Dr. Kory is a founding member of the Frontline COVID-19 Critical Care Alliance and the co-author of 9 influential papers on this disease. He was the former chief of the Critical Care Service at the University of Wisconsin and is a world pioneer in the use of ultrasound by physicians in the diagnosis and treatment of critically ill patients. He is a leader in therapeutic hyperthermia to treat post-cardiac arrest patients. Pierre, would you like to discuss the findings we've been discussing here?
I don't know if I can say enough about this paper and Juan and David's work and your work as well. If you guys recall, in October, around early October, a whole slew of results came out of like solidarity, number of things. So convalescent plasma and tocilizumab and remdesivir. And at that time, Paul noticed a signal around ivermectin. There's a few really kind of eye-opening studies, clinical trials, which a lot of people have been waiting for, showing this pretty profound impact. At that time, you could see every few days a trial would pop up on this preprint server or published. And we started to see this signal, and it got louder and stronger. That's when I saw Juan's. At that time, Juan was, I think, the sole author. I saw this paper, and I saw his first graphs, which now you guys have matured the graphs, and the data has been much more refined. But I saw what was clear to me as the solution to COVID. I've asked everyone, well, how do you explain this, right? So these are what I call natural experiments that have appeared to have occurred in the wild, right? So these events where certain regions suddenly start distributing ivermectin into the population. And then Juan saw that very early on. He's done this in numerous countries, and I'm sure you guys are going to talk more about the work, because the work is a lot wider and with numerous more examples than just Peru. But when I saw his Peru paper, and I saw how carefully he measured it and how he analyzed the data and how he combined not only these official databases of case counts and deaths, but he was looking at what was happening in the real world. He was looking at newspaper reports and health agencies as they were saying they were doing this and that. And so he was able to take those two sets of data and show a cause and effect in this really clear and credible way. And the thing is, it wasn't just one state. There was 8 states at the time. And then with the MOT program, again, reproducible. And so when I saw this, we were already becoming convinced that ivermectin was like, I've been calling ivermectin the penicillin of COVID-19. I mean, ivermectin to COVID-19, in my opinion, is like penicillin is to bacterial infections. And so that paper just sent me. And once I saw that paper, I remember I called Paul Merritt that day and I'm like, Paul, check your email. Look at this paper I found. And, I'm like yelling at Paul. I was like, this is it. We found the answer. I became so inspired by the work. I became so convinced of the efficacy. And I could see that what Juan was showing in these regions of the world, I could suddenly see a vision that this could be a global solution. You could see this play out across the world. And so, that's part of what's driven me for months. And I got to say, it was Juan's analysis and paper that did that. And so here I am today. I've been in a 3-month session. All I do is talk ivermectin 24 hours a day to everyone all over the world. And our manuscript features Juan's work, and that got published. And I think that's going to be available as a published peer-reviewed manuscript in about 10 days. And I hope, that paper with your guys' paper, I think those 2 papers are unassailable and hopefully will convince the rest of the world relatively quickly that really a mass deployment of ivermectin needs to be initiated. Governments need to start stockpiling, acquiring the supplies, figuring out distribution channels, and we got to get ahead of this thing.
Thank you so much for all your comments. That's great. Let me introduce Juan Chamie, a data analyst from Columbia, based in Cambridge, Massachusetts. He did postgraduate studies in statistics with a background in data analysis. He is the lead author who researched and analyzed the data for this study. Juan, would you like to describe the structure of the databases and your analytical approach?
Hi, Jennifer, of course. I'm delighted that Peru has a very detailed databases, and all of which are public, updated almost every day, and with an impressive level of granularity. They have COVID-related databases and all cases, fatalities, and each row represents one person. And for each person, they have age, they have sex, they have even education. So they have a strong database that is the main source for this study. We use Peruvian public databases to obtain all-cause deaths and COVID fatalities and COVID incidents. We look at the population over 60 because it's the population that has more risk of dying for COVID. We use most recent population census to get the number of people over 60 in every one of the 25 states of Peru. And we also obtained from Peru databases of COVID, of testing. We have databases of even ivermectin acquisitions and ivermectin distribution from the central government to the different states. So the data is, we have all the data possible to prove that like our research is well funded. We obtained information about ivermectin distribution from public reports given by governors and mayors in different places in Peru, and also large independent campaigns widely reported by the press in Peru. And also the outstanding MOT, the Mega Operación Taita, with extended coverage from government agencies and also from the media. We also use external data sources. We use the mobility reports from Google and the population densities from the Urban Center of Databases from the European Commission. We have a robust appendix with more than 150 references in the study and in the supplementary data. I think it's very important, it's crucial to state here that all this overwhelming data that we use for this paper is public. Anyone can access it and corroborate the data and our findings.
Thanks, Juan, for explaining all of that. I think everybody reading this paper would find that very interesting to know about, and just to know how they could access information if they wanted to look further into details of the statistics on the paper. This is very helpful to understand our data sources. I'd like to highlight some important details about how we brought this data together. We started our analysis with 8 states. Our findings were so significant, we didn't want to be accused of cherry picking our results, so we expanded our study to include all 25 states of Peru. The distribution of ivermectin conducted in different timeframes with local autonomy in each of the 25 states. Notably, Lima, due to political reasons, had its distribution of ivermectin 4 months after the other states. This served as a real-world control relative to the other 24 states. And as Dr. Scheim pointed out, I want you to visualize the expanse of this endeavor. Peru compares in size to an area in the US of Florida to New York to Minnesota. And in Europe, it would cover an area from Denmark to Italy to Greece. And we were aware that doing a thorough real-world study entailed eliminating variables that may skew the data. And as we pointed out, our analysis was performed for all-cause deaths and COVID-19 case fatalities, independently tracked. We ruled out possible distortions caused by varying proportions of younger and older people within the populations by including only people ages 60 and above. Case incidence data were not analyzed due to variations in testing methods and other variables. This ruled out significant extraneous causes of mortality reductions. This extensive study is effectively the step after a randomized controlled trial, where the trial is applied to real populations. This study of 25 different subpopulations has a total population of 33 million people. Now, Juan did mention too, importantly, that he brought in the 6 indices of Google tracked community mobility, which was really an important variable to assess.
Jennifer, I want to add to what you just said. I mean, you laid it out very clearly, and this is a really important part of the methods of Juan's analyses and your paper. But let's talk to either the lay people and the naysayers, because I use observational control trials all the time. I'm aware of confounders. You can think about confounders and you can assess data if you know what the confounders are. Now, everyone will say that could be unknown confounders. Okay, there's unknown confounders. But when you're seeing extremely large magnitude differences, that confounder is not going to be subtle. And let's talk about the confounders that you guys controlled for. So number one, people will say, and I've already been told this. In fact, one of the members of the NIH panel, when I presented Juan's work, you know what they said to me? They said, we've seen those graphs. Everybody has those graphs. New York City has those graphs where you see this peak and this fall. And he said, I'm not impressed with that. There's other infection control measures that are initiated over time. Now, I said, hold on. If you look, the temporal association, the timing that's repeated at different time points in different areas, followed by those reductions, is a little bit more than a coincidence. So we don't have the same graphs in every area, number one. But let's talk about lockdowns. Well, that's controlled for by looking at the Google mobility data. When you see those rapid reductions in excess deaths and case counts, you're seeing increases in mobility to supermarkets and workplaces and recreation. And so we know that, especially as the pandemic's gone on, guys, the lockdowns were basically dwindling. So you're seeing, so I think you're ruling out any impact of lockdown. Mask wearing has been ubiquitous in most countries. The US has got its issues, but most countries have been using masks throughout. I don't think there's been a sudden increase in mask use over that time. But the other things are the young people, right? We know that some of those graphs of deaths in a lot of other countries, we know that the rise in infections of young people will reduce the mortality rates. But guess what? You controlled for that. You looked at those over 60. Their mortality rates, they didn't just suddenly get younger, or their genetics or their immunosenescence changed. I mean, if you're over 60, and I say this all the time, when Juan's data shows that in April and May, in some of those regions, if you were over 60, you had a 50% chance of dying from COVID. And then suddenly in November and December, if you're over 60, your chances of dying are in the single digits. It sounds like some magical drug appeared to reduce that fatality rate. Just putting it out there, just a hypothesis. You guys already proved the hypothesis. Talking about young people confounding it, no. Talking about lockdowns confounding it, no. Masks confounding it, no. What about changes in testing, running out of strips, running out of PCR? Maybe this place tested more and they stopped testing here. You guys didn't rely on COVID case incidences. You looked at all-cause excess deaths. And so you didn't even rely on which were COVID deaths, because we know there's controversy on there. They might not have done it. Maybe they had a cold and they called it COVID. We all know those. You guys are looking at all-cause excess deaths in the population. So you're not getting confounded by that. And so I don't see any important confounder which gives a credible criticism of your work here. I mean, this is a real world example of how to change this pandemic. And so I'll tell you that I think this is a historic landmark paper. I think in history, when they look back and they see this work, I think it's going to be a historic global impact. And I don't believe I'm overstating that at all.
I just wanted to add concerning penicillin. They did studies. There was actually a published study of 15 cases of penicillin treatment. And after that study, they began mass production of penicillin, and it was ready in a year for distribution to the troops, the Allied troops in World War II. There were no studies. It was confirmed it was working there, and then it was deployed back to the civilian population. There were never any randomized controlled trials. And when you have 90% drops in mortality, the effect is so big that you just look at the data like Operation MOT. You go state by state, 75% mortality reductions drop different time periods after the distribution. This is quite clear. It's time to distribute national scale around the world.
David, let me add to what you're saying. So I'm going to translate it into the terms that I always hear. So back in the 1930s, 40s, the definition of sufficient evidence was a case series of 15 patients in where there was a dramatic effect of a medicine. So back then that was sufficient evidence. Okay. Because I'm always being told that my claims are based on insufficient evidence. Okay. Let's fast forward to 2021. Right now, Andy Hill, who's working for Unitaid and WHO, just on the randomized controlled treatment trials, he has 18 trials over 2,100 patients with an estimated reduction in mortality of about 75% just in that collection of trials. 75% reduction in deaths in trials which include over 2,100 patients. And yet, that's insufficient evidence in a pandemic with the mortality rates and the case counts skyrocketing. And yet most major governments around the world are still saying insufficient evidence. Now that's changing, right? Yesterday, Slovakia, right? Little Belize a couple of weeks ago approved it on their national guideline. Macedonia, right? We already know a couple of states in India have it in their guidelines. And I think, and then South Africa 2 days ago, now they're allowing passionate use. So you're seeing some sense creeping into some national public health agencies. When is that going to disseminate throughout all of them? And it's a global solution. It's going to happen. The four of us on this call know it's going to happen. The only question is when. It's not going to be soon enough, but it's going to happen.
Juan, would you like to talk a little bit about the current resurgence in deaths in Peru, in many of the states in Peru?
Yeah, it's very concerning. Now in Peru, cases are growing again. You can see now the increases in deaths, but not everywhere. The places where they know, like Iquitos or Ucayali or Tumbes, they know that ivermectin works. So there is no increase, zero increase in deaths. But in Lima, they are almost the same as the highest peak. So it's not like ivermectin is not working or there is a new strain. It's just places where they use ivermectin, they are not dead.
From what I understand, they knew that ivermectin was almost completely effective in Iquitos very early on. In fact, it was widely used in Iquitos because they saw those on ivermectin didn't die and didn't get sick. And so you're absolutely right. There's some places, they don't need the governments, they don't need the trials, they know it works and they're just using it. And so you're right, those places that are firmly convinced, they're not running into trouble.
Juan, would you like to discuss this a bit?
Yes, of course. Right now, there is a increase in deaths in Peru, in several regions of Peru, not everywhere. And all these pushbacks for political reasons are causing unnecessary increases in deaths. In December, the former president asked the government to continue Mega Operación Taita and praised ivermectin as a main cause for the reduction in deaths. So after MOT, Mega Operación Taita, excess deaths went to close to zero. But the Ministry of Health, who worked for him, declared in the media that ivermectin, there is no evidence that ivermectin works. And the Ministry of Health is saying ivermectin is not recommended. The big media in Peru is also saying ivermectin is not the solution. So I think this is the reason. And Mega Operación Taita was a total success, and the decrease was like immediate. But then you can see in the same places that deaths are increasing again. In Lima, especially, and in places close to Lima, and even states not very close to Lima, where they don't believe so much in ivermectin, the deaths, excess deaths, are increasing rapidly. Some places, like Iquitos, where they have been using ivermectin since May, hospitals are empty. There is not any increase in deaths. Like Ucayali, still, no one is dying in excess in some states in the north of Peru, some states in the south, but in the biggest states where they are more influenced, the deaths are increasing. They are not using ivermectin in the hospitals, the campaigns. So lockdowns never work in Peru because they have the lockdowns only at night and in the weekends. But people have to work to buy food.
It's my belief that Peru is going to save the world before Peru saves itself.
Absolutely.
I wanted to add that the Nobel Prize laureate for ivermectin, by the way, ivermectin, it's been distributed around the world for various diseases in 3.7 billion doses. It's as safe as aspirin or perhaps safer. The Nobel Prize laureate, now they've seen the data, we've been in touch with them. They are enthusiastic about the use. So if the Nobel laureate is positive for this, that says a lot also.
David, you brought us together because our group, the FLCCC, we are over the moon when we get a letter from Professor Amura and his team, and they've written us letters of encouragement. They really support our manuscript. They translated our manuscript into Japanese, and it's actually on their institute's website. And I'm sure your papers too. And Juan, you told me that Professor Amura, he's lectured using some of your analyses, right? Some of your slides. And so it's a great partnership.
Yes, this is wonderful, gentlemen. Thanks for coming together like this so that we could talk about this paper. These outcomes make ivermectin a compelling option as an interim measure for large-scale deployment on a national and international scale, and would very effectively complement the vaccine program. So this has been a really good discussion. Thank you, gentlemen, for joining me today.
Sounds good.